Welcome back to the Finding Genius video series. I'm joined with Zack, the founder of Ophelia. Ophelia is focused on the serious opioid epidemic in the United States. It offers individuals who struggle with opioid addiction medication-assisted treatment through a telemedicine platform. Ophelia is backed by General Catalyst, Refactor Capital, Menlo Ventures, the founders of Flatiron Health, Warby Parker, Harry's, PillPack, and more. Zack, thank you so much for joining us. I'm looking forward to learning quite a bit about Ophelia.
Pleasure to be here. Thanks for having me.
Zack, I think just set the foundation to make sure that everybody understands where we're starting. Could you discuss the opioid epidemic, a bit about the origins of it, the communities it affects most severely, but then I think since it's been in the conversation for a few years now, maybe a bit more about where we stand today, and kind of how COVID-19 affected the recovery from it as well.
Sure. Well, opioids have been around in some form or another for a very long time. The most recent epidemic was catalyzed by, in part, the pharmaceutical industry. So, most notably, Purdue Pharma, famous for mismarketing its prescription opioid OxyContin as being less addictive than other forms of prescription painkillers. Meanwhile, the pain was named as a fifth vital sign. So doctors around the country were sort of compelled to treat pain as if it were, just like a heartbeat. And you had Purdue Pharma basically unleash its marketing team on doctors, convincing them to prescribe these medications for pretty much anything. After a period of time, it became clear that OxyContin was very addictive. The government started to crack down on rogue prescribers, pill mills as they were called. The supply of prescription painkillers was effectively, diminished, but you had a lot of people who were on painkillers for a long time and had become physically dependent on the drug, but they no longer had access to pills, so they turned to the street, started using heroin in higher frequencies. Heroin is, much like OxyContin, but cheaper, more potent. Eventually, the drug dealers got smarter and started, or more evil, if you will, and started cutting their heroin with fentanyl. Fentanyl is much more potent than heroin and cheaper, and so it's an easier way for drug dealers to achieve the same effect at lower cost. But given how potent and lethal fentanyl is, the result on the American public has been a dramatic increase in overdose deaths. Now, as a result of the rise in opioid addiction, the government started pouring a lot of money into research for addiction treatment. And about, 2 decades have passed. We have a treatment that works extremely well. It's called medication-assisted treatment. It looks a lot like the treatment that you would get for depression or anxiety. So it's medication for withdrawal and cravings, plus support and therapy long-term. There's very little dispute about whether or not it works. The problem is that it's simply not being implemented for a whole host of reasons. And so now we're at a point where Americans are addicted to opioids, reliant on street drugs that may kill them at any dose. There is a treatment that works. They're simply not getting it. And Ophelia exists to make that treatment more accessible. Meanwhile, COVID has exacerbated the crisis for a number of reasons. Firstly, the effects on mental health are sort of well documented as a result of, joblessness and self-isolation. However, the brick and mortar rehabs were really not positioned to adapt to the new normal. A lot of them started downsizing, going out of business, and border restrictions complicated the supply of drugs into the country. And so now you have a situation where there is increased demand for addiction treatment, reduced supply of addiction treatment, and the result has been escalating prices on the black market, and in particular, a huge black market for the medication-assisted treatment drug called buprenorphine.
And could you discuss, before we get into more of the epidemic and medication-assisted treatment, can you discuss your background and how you made your way into this space and the research that you've done around it?
Sure. So, first of all, my background was not in healthcare. I started my career doing science research and then went to work at a solar energy startup. Eventually decided I wanted to work on something of my own, but had never studied anything related to business. Got my MBA at Wharton. And while I was getting ready to graduate, lost a girl I loved to opioids and started working on Ophelia pretty much the same day. At the time, it was just an idea. I recognized that I didn't have a whole lot of training in medicine, and for all I knew, the first doctor I talked to would tell me to go away and work on something else. But what I found was that the medical community thinks about addiction treatment very, very much like the drug-using community does. And it turns out the treatments that are recommended look very different than the traditional rehab industry that we know today. And so over a period of a couple years, I put the business together, started operating it in early 2020. We actually launched around the time of the public health emergency. So we have been telemedicine only since our inception. Went through Y Combinator in early 2020, raised our seed round in March, and then recently closed our Series A, and are in the process of expanding across the country.
And you just mentioned providers and their perception of medication-assisted treatment. Can you go a bit deeper into that and maybe where the discussion is around that, how that's evolved, and specifically how that works? Because I know there's clinics across the country, but you're taking a more digital approach to the solution. Could you go a bit about the approaches that have been tried here and what medication-assisted treatment actually is?
Sure. So, put yourself in the position of someone who is addicted to illicit drugs. You are effectively centering your entire life and all of your decisions around getting your next dose. If you stop using, you're going to go into withdrawal. And the only thing that will help you with your withdrawal is medication, specifically buprenorphine. And so it's pretty well understood, even by people who are, stigmatized to the idea of chronic medication-assisted treatment, that at least a medicated detox, starting medication to get stable, is the right first step for everyone so they can stop using dangerous drugs that might kill them tomorrow. It turns out that continued medication is far and away the best path for most people in terms of mortality reduction and restoration of quality of life. So we know that without continued medication, about 90% of people will be using again within 3 months. And after a period of abstinence, you're now at an increased risk of overdose and death than you were before entering treatment to begin with. So that's fact one. Fact two is that there are about 15,000 rehab programs in this country. 2/3 of them do not prescribe any form of medication, nor are they run by doctors. And so
what are those rehab programs focusing on?
They, for all intents and purposes, live outside of the medical system. They are sober living homes. They'll provide a place for you to go stay. So, any fancy rehab that you may have seen on TV probably doesn't have a doctor on staff and isn't prescribing you medication, or if they are, they're prescribing you medication for a very short period of time and then releasing you without a plan. But largely, it's the other components of treatment that are certainly important, but without medication itself, highly ineffectual for most people. So the situation in this country today is that we have a treatment that works, reduces overdoses by 5x within the first year. It's already covered by pretty much every insurance because it saves the healthcare system a lot of money. People really want it. They want the medication, yet it's way too hard to get, and the vast majority of them are just buying the same medication on the street from their drug dealers for literally thousands of dollars a month in cash. Roughly 20% of people are getting treatment, and a much smaller fraction are getting medication-assisted treatment. And there are, people in every industry that haven't quite caught up with the science, have their own personal biases, and are fighting the idea that a chronic medication to treat a drug addiction counts as recovery. Whereas the data itself is crystal clear, and You can go to the U.S. government website, SAMHSA, and you'll see on there medication-assisted treatment is the gold standard, but for many, many reasons, it's not being disseminated nearly to the extent necessary to reduce this crisis in this country.
So how do you, Ophelia, I mean, when you went through Y Combinator and you were thinking about the product in order to maybe reduce the shortage, kind of think about medication-assisted treatment and address it in these populations where it's not being addressed, how did you begin to productize that or think about this from a technology standpoint of the solution?
Yeah, well, I mean, it started with an understanding of the consumer psychology, which I knew intimately through my personal experiences. And this girl really wanted to get better. She had a good job. She was a private person. She did not want to go to rehab. She didn't want anyone knowing about her problem. In fact, the concept of rehab to her and to most people in itself represented a failure. A lot of people think they slipped up, they have a bad habit, they don't want to consider themselves as being diseased. And if you check yourself into rehab, you've basically self-identified as a drug addict and admitted that you can't do it on your own. So she wanted help, and she had a much easier time getting this medication from her drug dealer than from a doctor. And it turns out that this is, the default solution for most people. So automatically, I knew there was acute demand for the medication because people don't like being addicted to pills or heroin. They want to stop. They know they need the medication. The medication is too hard to get. And when they do get it, they don't get it correctly. Drug dealers are not doctors. They're unreliable. If you run out of medication, you're going to go into withdrawal. You may start using it again. You may overdose and die. So step number one is get people started and stable on medication so they can stop playing Russian roulette with their life. Step two is create a treatment plan that works for people and depends on their medical needs and also their preferences. One of the core insights to me was the existing rehab industry looks the way it does because of messed up incentives between providers and payers. A large percentage of patients affected with opioid use disorder are on Medicaid. Medicaid rates are low. Most Medicaid organizations, MCOs, pay fee-for-service to providers. And so if you're a brick and mortar, you may have a high cost structure, fixed costs in the form of salaries, physical assets. You're on a fee-for-service contract with the health plan. Each service doesn't pay very much. The only way you can be profitable is by over-serving patients and overbilling their insurance company, which is why if you want to use your insurance, you're choosing between a program that's going to make you come in a couple times a week, sit in a waiting room for 2 hours, be part of a group, etc., pee in a cup once a week, or you can just call the same person who sells you pills and heroin and pay a bunch of money to get the same medication. We recognize that if you force people to do things that are not medically necessary, and maybe they will need someday, but don't think they want up front, they're not going to choose you, they're going to go to the street. So we wanted to make it as easy as possible for people to choose doctors instead of drug dealers. We found that telemedicine was ideal for that because it reduces the barrier to opt-in, but it also decreases friction over time. So if you think about the perspective of a drug user, often people go to rehab, as they say, when they hit rock bottom. It may be that you have to drive 2 hours twice a week to a clinic, but when you're in despair, it's worth it. 3 months later, when you start to feel better, the demand becomes less acute, and you're much more likely to drop out. We found that with telemedicine, we fit neatly into the patient's life. They can keep their job, they can keep their family, they can do it privately if they want to. And as a result, we see opt-in from people who were previously not seeking addiction treatment at all, and far superior retention to historical industry standards.
Very interesting. And I guess building on that, when you're thinking about it from the perspective of, you had Purdue Pharma, you had providers from the best medical schools across the country prescribing this for so many years and creating addiction for an entire population. I think it's about it's number one cause of death for Americans under the age of 50. And now you have folks that are addicted to this and you're trying to reduce the stigma. How are you reaching the patients and letting them know that Ophelia exists as solutions? They don't need to check into rehab. And then how are you also reducing the stigma and letting them know that there is solutions that can help in a way that is that done through technology? What's the best way of reaching people that are affected by it?
Yeah, two really good questions. So first of all, the way that traditional healthcare providers get patients is through referrals from the hospital, from detox facilities, from primary care, from behavioral health. Today we look much like a direct-to-consumer, technology company. We are acquiring all of our patients ourselves through targeted digital advertising, and this is pretty, I think, unusual in healthcare because most healthcare sectors are not consumer sectors. People don't pay $1,000 a month for insulin to treat their diabetes. They go to a primary care doctor and get referred or get treated directly. So for us, certainly we want to plug into the healthcare system. That's a major goal for us over the next couple of years. Work with existing providers to treat their patients. But today we found that there's tremendous demand from people just by showing them ads on the internet. The question around stigma is an important one and a harder one, frankly. There is stigma, as I said, not just around drug addiction, but around medication-assisted treatment. And there are a lot of reasons for that. So, the idea promulgated by people who believe in abstinence-based treatment is that if you're on medication, you're not really in recovery. You've just traded one drug for another. The medical community prefers to think about buprenorphine the way that we think about, insulin for diabetes or SSRIs for depression. Addiction is defined as a dependence that causes harm to your life. But if you're dependent on a medication that is keeping you alive and allowing you to restore your personal and professional relationships and be happy again, that's not addiction. That's dependence on a medication. Tackling stigma and changing the minds of people who have very strong conviction about this topic is a challenge that is honestly too tall for a startup like us. Certainly we can insert ourselves into the conversation, but we'd be fools to think that we can change the stigma around drug addiction and around medication-assisted treatment ourselves. The least we can do is offer people privacy. So if they are embarrassed to be using drugs, if they're embarrassed to be on medication-assisted treatment, because that stigma exists, well, if we can't solve the stigma, let's at least give them the privacy to do it so that they don't need to be exposed to their friends and family and subject themselves to that stigma. And telemedicine is ideal for that because we target patients directly and we allow them to do it from the privacy of their home.
Interesting. And when you think of, I want to ask a question after this about the broader healthcare ecosystem and how it failed this population and maybe how it's continuing to fail. But when you think about the government and the regulation that they put, and you are acquiring customers through digital channels, are there laws and regulation in terms of what you can message, what you can't message? How do you navigate that in terms of the platforms that you're using and thinking about it, both from a business too, in terms of acquisition costs, and I'm sure that comes up quite a bit. But that's two things that are hard to wrestle because there's a very serious impact that you're creating, but then there's also the business side of it.
Well, I think the government is enemy number one in this crisis. I could rattle off 10 regulations that get in the way of people accessing medication-assisted treatment. I won't do that. I'll give you a few. First of all, in order to prescribe this medication, clinicians need a special license from the DEA called an X waiver. Fewer than 5% of clinicians in this country have that waiver. 40% of counties in America don't have a single prescriber with a waiver. And about half of the clinicians who are licensed to prescribe buprenorphine are not using it because they don't have the support systems to do so. They work in hospitals, they work in primary care, and it's just too hard. And once you have the waiver, there's a cap on the number of patients you can treat. So right away, the supply of eligible prescribers is dramatically depressed by arbitrary regulation at the level of the federal government.
And just to double click on that one, was that an overcorrection made by the government because of the opioid crisis? Or was that something that's a historic law?
Yeah, I would say that. So, listen, there's no rational explanation for why this license exists. You don't need a special license to prescribe OxyContin, yet you need a special license to prescribe buprenorphine to somebody who is addicted to OxyContin. Right. Doesn't make any sense, right? The historical explanation is that buprenorphine is in some form a derivative of methadone. Methadone is a full agonist. It's much more highly regulated than buprenorphine. To this day, it has to be dispensed in person. So if you're on methadone, you're going to a clinic every day. Buprenorphine is a partial agonist. There's a ceiling effect on it, so you can't overdose from it. For someone who is opioid tolerant, you can't really get high from it. It's just enough to give you withdrawal and cravings relief, and to block your opioid receptors should you lose willpower and go do a bunch of heroin, because it has a greater binding strength than heroin does, and in effect you won't overdose on the heroin either, right? But because it was a form of medication-assisted treatment like methadone, and methadone was so highly regulated, the government wanted to make sure that people who were prescribing it had appropriate training. So they put these training requirements in place and associated it with a license that you got once you finished training. 20 years later, there is no good reason that it still exists except for political inertia, and that's it. And you could talk to any medical organization in America, and they won't just tell you that the X waiver is nonsense. They're probably actively lobbying to get rid of it, and there's a lot of movement in Congress to make sure that it goes away as well.
Interesting. Okay.
Regulation number 2. In order to prescribe any controlled substance in this country, traditionally, one in-person visit was required. Buprenorphine is a Schedule 3 controlled substance. As I said, because of the X waiver requirements, 40% of counties in this country don't have a single prescriber. And so if you want to go to a program, you are driving, a while to get to someone who can prescribe you this medication, and you couple that with the stigma of having to show up in a clinic or talk to a doctor, and you've got, the problem that these ED med companies are solving magnified by a million, because you go to your primary care doctor and tell them you have an opioid problem. Well, you've crossed that barrier, but they still can't help you because they don't have a waiver, right? You got to go to a program and self-identify with a bunch of other people that you don't associate with. The origins of this were an incident that happened in 2008 when an individual bought some drugs from an online pharmacy and overdosed. The law is called the Ryan-Haight Act, and it basically says that in order to prescribe any controlled substance, you need to first establish a patient-provider relationship. In the statute, they defined patient-provider relationship as an in-person evaluation, and then there was a clause for telemedicine, but they punted on explaining what telemedicine meant. And for many, many years, the DEA was pressured to define this telemedicine exception for providers who are practicing legitimate medicine to treat patients without the in-person visit. In 2018, the Support Act compelled the DEA to finally come out with this definition of telemedicine as an exception to Ryan-Haight. They were supposed to announce their findings and a new process in October of 2019. They came out and said, we need more time. 6 months later, COVID hits, everyone forgets about it, and the public health emergency temporarily waives the in-person visit requirement for all controlled substances. So now we finally get to see the benefits of telemedicine, and anyone who's looked at the data can show you that it is dramatically increasing access and dramatically improving retention. Now, nobody knows what will happen to the in-person visit requirement once the public health emergency ends. And as you can imagine, there's a lot of uncertainty in both the investor community and the provider community about what to do about it. Everyone's waiting to see what the government is, what Congress is going to do. There are many avenues they could take to make the in-person visit requirement permanently irrelevant, particularly for buprenorphine. I'm fairly confident that they will, but they're certainly taking their sweet time. So that's regulation number 2. I'll give you one more, which is a little bit less direct, but equally important. Medication-assisted treatment not only saves lives, it also drastically reduces healthcare costs. So somebody who starts medication-assisted treatment, saves the healthcare system roughly $10,000 in the first 3 months because they're avoiding emergency room visits and all of the other costs associated with comorbid conditions like IV injection.
Right.
So if you just paid for medication-assisted treatment, fewer people would die, and you would save money. Most medication-assisted treatment is paid for through insurance companies, largely through government insurers like Medicaid, and these programs are underfunded and do not pay sufficiently for it. So the solution that Washington has taken, which is its classic approach, is to throw more money at programs that don't work. And so you see every couple months $1 billion allocated to community health initiatives to treat substance use disorders. That money gets funded to states, which go to counties, which then go to programs that frankly don't work very well. If instead of spending more money, they simply paid for the treatment that works, fewer people would die, and there would be more room in the government budget and lower burden on taxpayers simply by reallocating and redefining payment for this treatment.
And are private insurers already covering that treatment, or are they waiting for CMS to change their standard?
Everybody covers it,
but not to the reimbursement rates.
Whether or not they cover it adequately is a separate question. So here's an interesting example. In 2020, CMS, which governs Medicare and to an extent Medicaid, published its physician fee schedule with its codes and rates for different conditions and treatments. And they announced a bundled payment for telehealth-based medication-assisted treatment that covers medication management, counseling, therapy groups, etc., as a bundle, and pays very well. Between $350 to $400 per patient per month, which would be more than enough to incentivize more providers to provide this level of care to patients. But CMS has very limited power, and so most Medicaid and Medicare in this country are managed by managed care organizations. The managed care organizations get to set their own standards. So we're dealing with Medicare plans for managed by companies like Aetna and United, and even though CMS has these codes, they don't have to use those codes, and they don't have to pay at that rate, and certainly not true for Medicaid. So CMS has very limited power. They can set guidelines, but unless the payers themselves follow suit, nothing will get implemented. The irony is that this is not just a social imperative; it's smart business. If you want to improve your bottom line, stop paying for ED visits, pay for treatment that works. Your shareholders will be happy, regardless of the fact that you're saving lives. It's craziness.
And I guess understanding that there's so much red tape and restriction, and the entire process has just become extremely convoluted with providers, private insurers, what Purdue Pharma did. Are you hopeful in kind of the history of this epidemic and how things have kind of affected the American population and the types of communities it's affected? Are deaths from this on the decline? Are there more treatments? Are you hopeful that in the next decade we would start to see some more positive solutions here and decline, or no?
I'm very hopeful because it finally seems like the people in power understand the facts and are working to make change. Now, change happens very, very slowly, but we suddenly have a whole host of data as a result of the public health emergency in favor of telehealth treatment for medication, for substance use disorders. But I think more importantly, we've now sort of found ourselves in a new equilibrium, and government tends to follow inertia, right? So it would be, in my opinion, it would be harder to roll back to the status quo and say, okay, everything you've been doing for the last 2 years, patients and providers, you can no longer do, go back to normal, than it would be to simply make the existing changes that were temporary permanent and allow everyone to go on their way. So I am very hopeful. I'm also hopeful that we don't need necessarily the government or payers to treat patients, because the reality is, most people out there are spending way more than we need to cover our costs on drugs or medication on the black market, even if they don't have a lot of money. The vast majority of our patients are Medicaid enrolled, meaning they could go to an in-network provider and pay nothing if they wanted to, They choose to pay us $195 a month if we're not in network with their plan, because that's how bad the existing options are. And compared to the cost of $1,000 a month, it represents dramatic cost savings to them.
Interesting. And what are the statistics? I mean, how many people, can you talk more about the epidemic itself in terms of what types of communities this is affecting? How many Americans are struggling from this still? Kind of, are those declining? Are those increasing? Is it starting to hit other communities?
So it affects everybody. And the reason it affects everybody is because many people got started with painkillers through prescriptions from a doctor. And that means people who have health insurance and see doctors.
Right.
So
right.
Medicare, Medicaid, commercial, it's everybody. I would say that the rural community is least well served by this problem because of the in-person visit requirements and the lack of available treatment programs in less populous parts of the country. But it's really a problem that affects everyone. Opioid overdoses are on the rise, and a lot of that is due to COVID and the frictions that were introduced into the system by, for all of the reasons that I described earlier.
Right. And you discussed the regulation that needs to be changed in order for medication-assisted treatment to continue to improve the lives of these people. Can you talk more on, less on the government side, but on the healthcare ecosystem side of where kind of pharmaceutical companies, providers, they failed the American public? What has changed or what needs to change so this never happens again?
So how do we avoid another epidemic? How do we avoid the problem?
For what failed the first time around that maybe is still there as a possibility?
I think that most of the problems in American healthcare derive from misaligned incentives, specifically due to payment structure. Fee-for-service incentivizes providers to do things that are not necessarily in the best interest of their patients, but that help them get paid. So if patients wrote more prescriptions, if doctors wrote more prescriptions, patients would keep coming back to them. They could bill the insurance company. It had nothing to do with health outcomes. It had everything to do with service volume and getting paid. The same problems pervade the addiction treatment industry. As I described earlier, the treatment you get when you go to an outpatient rehab program is not designed to optimize for your health. It's designed to optimize for the treatment program's profits. And so if the healthcare system wants to reduce costs and improve outcomes, it needs to pay for things that actually improve health at the lowest possible cost without worrying about individual service volume. And that means moving to value-based care, or at the very least, episodic bundles. So what I would like to say is, health insurance company, you're on a fee-for-service contract with this other program. They're providing excess services and charging you $500-$600 a month. Let's forget about service volume. I will promise you better outcomes and greater opt-in. We'll serve the invisible patient that you don't even know exists and might wind up in the ED tomorrow. And you can pay us less than that because our costs are lower. But if you force us to tie our revenue to individual services, you're screwing up our incentives, which leads to an inferior patient experience, reduced opt-in, and decreased retention. And that serves nobody.
And is that how Ophelia generates revenue? Is it on a value-based care model and measuring outcomes and thinking about that?
Well, as you can imagine, it's insurance companies are slow. We started as a cash pay business. We're slowly making the transition to reimbursement. Some of our contracts will be fee for service because that's all we can get, and we'll be able to be profitable on those contracts. Some of our contracts will be bundled, but for the most part, we're on a bundled $195 per month payment in cash from our patients today, and we're doing just fine.
Right. Zack, thank you so much. I really appreciate it. This is very interesting and insightful, and I wish you all the best. I know this is a big problem you're tackling.
So thanks so much for having me.
Thank you, Zack.